We are on live, sir.
Yeah. So, madam, we are live now. Shall we start?
Yes.
Good evening, doctors. I Shumon on behalf of Shinde Healthcare, welcome you all to this another interesting session on infertility and how it is being discussed. So, thank you very much, doctors, for your valuable time to share this important topic with us. And it is our honor to introduce Dr. Veena Shinde, madam. Madam, you have MBBS, PGO, MD, postgraduate AFP. Yes. Madam is currently attached with BSCS Hospital, Cloud9 Malad. And in terms of academic activities, Madam published many research articles in national and international peer-reviewed journals, participated in various conferences, and Madam has huge experience in terms of clinical research experience also. There are many phase 2, phase 3 studies and many more. In terms of awards, Madam received many awards, out of which Certificate of Appreciation, Lions Club of Vancouver, and many more. And in terms of PV programs, Madam is also associated with many other initiatives, PV programs, and camps, many camps also conducted. So with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the drop box of the Shield Connect page. So once the talk will be over, we can have a short discussion on this topic with Madam. So thank you very much, Madam, once again for your valuable time on our platform Shield Connect, and over to you for thank you very
Thank you
much.
for the very kind introduction. And it is a very interesting topic, stress and infertility. It's a very, very important aspect of infertility which we are dealing with. I hope you all enjoy the session. Stress and infertility. There is a new epidemic of young India. India faces a high burden of infertility with 22 to 33 million couples in the reproductive age suffering from lifetime infertility issues. 1 in every 4 couple is in the reproductive age in India struggle with infertility. More and more young Indians are finding it hard to conceive. At least 10 to 15% of married couples are experiencing fertility issues. 40 to 50% of the cases are attributed to problems with women, while rest it is men, that is about 30 to 40%. The surprising fact is that male infertility in India is on the rise with every passing year. Factors that have impacted the infertility rate in India: unhealthy eating habits, older couples, stress, smoking, alcohol, lifestyle problems, medical reasons, using of too many contraceptions, 40% male factor, 40% female factor, 10% combined factor, and 10% unexplained infertility. Being diagnosed with infertility, everyone reacts to the diagnosis of infertility differently. Diagnosed partners can experience several emotions like shock, surprise, denial, a sense that the diagnosis is really not true. This can also be described as feeling numb or not knowing what to do. Anger and frustration, this can be expressed as why is this happening to me, or feeling angry at others, anxiety, fear, panic. All thoughts are very confusing. Isolation, feeling different from others and feeling out of touch with your partner. Sense of loss, there are many aspects of grief covering loss of pregnancy, loss of motherhood and fatherhood. These can continue through all stages of infertility. Can stress be a contributing factor for infertility? Yes, stress affects fertility, but people were unable to discover why and what to do. Social stigma can aggravate the stress levels. Stress and infertility, link between stress and reproductive dysfunction has been well established. Psychological stress experienced by the female or male partners of infertile couples has been associated with low conception rates. Data from animal models suggest psychological stress may be a major contributor to both male and female infertility. Stress can compromise every aspect of fertility, including libido, sperm quality, ovulatory capacity, and implantation. Stress influences reproductive function at all levels. Stress can interfere with reproductive function at the level of the reproductive axis. It can suppress libido, reward and mating behavior at the level of the brain, particularly the ventral tegmental area. It interferes with the hypothalamic gonadotropin releasing hormone pulse generator and luteinizing hormone and follicle stimulating hormone release from the anterior pituitary. It suppresses oocyte maturation, ovulation at the level of the gonads, as well as increasing the likelihood of ovarian cysts and affecting both ovarian and testicular steroidogenesis. Stress is also detrimental to pregnancy outcomes, post-conception, reducing the likelihood of successful blastocyst implantation. The hypothalamic pituitary adrenal axis. Upon encountering a stressor, medial parvocellular corticotropin releasing hormone and arginine vasopressin neurons of the hypothalamus receive input from the several brain regions, including the amygdala, brainstem, prefrontal cortex, and stimulate corticotropin releasing hormone release into the median eminence. CRH acts on the anterior pituitary through CRH receptor 1, leading to the release of adrenocorticotropic hormone into circulation, a peptide hormone derived from the propiomelanocortin. ACTH stimulates glucocorticoid release to regulate glucose and fat utilization and storage, memory, immune function, and other stress coping strategies, as well as negatively feeding back on glucocorticoid and mineralocorticoid receptors in the hypothalamus and hippocampus to suppress further HPA axis activation. The hypothalamo-pituitary gonadal axis. Hypothalamic medial preoptic area, KISS-peptine, KISS1 neurons stimulate the gonadotropin inhibitory hormone neurons into gonadotropin releasing hormone pulsatile release into the median eminence. GnRH release stimulates the release of gonadotropins LH and FSH from the anterior pituitary. This in turn leads to release of ovarian steroids, mainly estrogen and progesterone, that can carry out both negative and positive feedback actions depending on the stage of the ovarian cycle. In males, gonadal release of testosterone produces inhibitory actions on GnRH, gonadotropin secreting negative feedback. Pituitary gonadotropins also stimulate steroidogenesis. Intersection of HPA and HPG axis. Corticotropin releasing hormone can directly inhibit the gonadotropin releasing hormone pulse generator, leading to suppression of pituitary gonadotropins, LH and FSH, in turn resulting in diminished oocyte maturation and steroidogenesis. Glucocorticoids can directly act at the level of the pituitary to suppress gonadotropin release as well as to exert suppressive effects within the gonads. CRH release from the paraventricular nucleus of the hypothalamus activates locus coeruleus LC neurons, increasing noradrenaline production. This stress-induced increase in sympathetic activity can then increase sympathetic innervation of the ovary, contributing to the development of ovarian cysts. What does research convey? Evaluation of predictor factors of psychological distress in women with unexplained infertility. Ingrid Noels, Sylvia Dodin, Stephen Dufour, Marie-Eve Burgeon, Jessica Livy-Brie, and Sarah Maha Lacroix. Anxiety and depressive symptoms are common among women with unexplained infertility, and strategies should be developed to better support and treat this high-risk population. Depression and emotional stress is highly prevalent among women with recurrent pregnancy loss. In the prevalence of psychological stress and moderate severe depression, higher for women with recurrent pregnancy loss than pregnancy planners trying to conceive naturally. What is already known? RPL has a significant emotional impact on couples, especially the women. Previous studies have shown inconclusive results. In summary, both psychological stress and major depression are significantly more common among women with RPL than in those trying to conceive naturally. It has wider implications. The study should entail a heightened awareness of mental distress among care providers for women with RPL. The investigation holistics stress in infertile women and relation to demographic characteristics in women who referred to Yaz Infertility Center, Fatima Ghavi, Leli Moselane, Jad Masomed Golestan, Nahid Yari, and Sabat Iteberi. Infertility has a significant impact on infertile women's mental health. it is important psychological approach consider an important part of treatment inside other medical treatments. Middle East Fertility Society Journal, the distribution of stress level among infertility patients. 22% of infertile patients in the clinic experience stress mainly associated with the duration of their infertility. In women, stress-induced anovulation. The common causes of anovulation and amenorrhea is stress-induced anovulation is seen in 34%, hyperandrogenism and PCOS in 29%, hyperprolactinemia in 13%, premature menopause in 12%, Asherman syndrome in 5%, and others 7%. How stress affects ovulation. When a person is under chronic stress, the HPA axis is activated, which leads to increased level of cortisol and CRH. The increased cortisol and corticotropin releasing hormone can suppress the normal levels of reproductive hormones, which can potentially lead to abnormal ovulation, anovulation, and amenorrhea. How stress affects ovulation. When there is presence of adequate estrogen and there is stress-induced activation of the HPA axis, higher amount of LH released. Studies have found that increase in LH was mostly probably associated with increase in adrenal progesterone, which should feedback negatively on the gonadotrophins in the pituitary, produce LH that accompanies the release of cortisol in response to stress. It has been reported that progesterone can stimulate LH secretion by acting directly on the pituitary. Because of the stimulation of LH secretion, this may provoke a premature LH surge and thereby interfere with proper follicular maturation and ovulation. Furthermore, elevated LH concentrations at different stages of the menstrual cycle may have conflicting effects on the maturing follicle and on the developing oocyte and may result in early pregnancy loss due to the egg not implanting properly. Impact of stress on oocyte quality and reproductive outcome. The increased cortisol as well as oxidative stress levels affect granulosa cells function probably by inducing apoptosis. The granulosa cell apoptosis result in reduced estradiol 17 beta biosynthesis in the ovary, which reduces growth and development of follicular oocytes and induces oocyte apoptosis. Apoptosis deteriorates oocyte quality, leading to poor reproductive outcome in mammals, including human. List of studies showing effect of stress on ROS production and oocyte quality. Stressful life events cause release of stress hormone and impair follicular maturation in the ovary. Stressful life events lead to maladapted lifestyle behaviors, that is alcohol and cigarette consumption. Stress induces poor IVF outcome. Stress generates ROS and reduces oocyte quality. Alcohol and cigarette consumption reduces fertility in women. Stress and endometrial receptivity. The human endometrium plays a vital role in providing the site for embryo implantation and maintaining the normal development and survival of the embryo. Recent studies have shown that stress is a common factor for development of unexplained reproductive disorders. The non-receptive endometrium and disturbed early maternal-fetal interaction might lead to infertility, including the repeated embryo implantation failure and recurrent spontaneous abortion or late pregnancy complications, thereby affecting the quality of life as well as the psychological status of the affected individuals. The impact of stress on human endometrium. The brain, the hypothalamus, and the pituitary, the HPG axis disruption, decrease in GnRH, increase in FSH, estrogen and progesterone are altered. Lower GnRH level, lower FSH and LH ratio, altered the secretion of estrogen and progesterone, inhibition of epithelial and stromal cell proliferation, inhibition of stromal cell differentiation, altered endometrial gene expression, impaired endometrial receptivity, and ultimately affects the embryo implantation and development. In male, stress on semen parameters. According to the American Society for Reproductive Medicine, infertility affects men and women equally, and semen quality is a key indicator of male infertility. Men who feel stressed are more likely to have lower concentration of sperm in their ejaculate, and sperm, they are more likely to have misshapen or have impaired motility. It may trigger the release of steroid hormones called glucocorticoids, which in turn could blunt levels of testosterone and sperm production. Another possibility is oxidative stress, which has been shown to affect semen quality and fertility. Effect of psychological stress on fertility hormones and seminal quality in male partners of infertile couples. Persons having abnormal hospital anxiety and depression score had lower serum total testosterone, higher serum FSH and LH than those persons who had normal hospital anxiety and depression score. Sperm count, motility, and morphological normal spermatozoa were lower in persons having abnormal hospital anxiety and depression score. Effect of emotional stress on sperm quality. Male patients with idiopathic infertility were selected after evaluation of psychological stress to evaluate a positive effect of a stress therapy on their semen quality. Data showed that necrosis and apoptosis were higher and the number of healthy sperm was significantly reduced in both groups of stressed men compared to the reference values. The number of healthy sperm was significantly higher in the treated group after therapy, indicating a recovery of sperm quality. The effects induced by stress also seem to include meiotic and structural alterations in sperm cells. The main alteration in sperm pathologies were related to apoptosis and necrosis. Marginated chromatin and swollen and badly assembled mitochondria were the typical ultrastructural markers of apoptosis, and reacted or absent acrosomes, nucleus, and disrupted chromatin and broken plasma membrane were signs of necrosis. The Assisted Reproductive Technologies Journal, Relationship between psychological stress and reproductive outcome in women undergoing IVF treatment, psychological and neurohormonal assessment. The purpose is to evaluate whether psychological stress as well as changes in the hypothalamo-pituitary adrenal axis and sympathetic nervous system at different time points during a first in vitro fertilization cycle correlates with the reproductive outcome. The conclusion show state anxiety is associated with both pregnancy rate and live birth rate in IVF patients, an effect that is partly mediated by activities in the HPA and SNS system. The effect of psychological distress on IVF outcomes, reality or speculations. Rates of stress, anxiety, and depression among IVF patients are higher than in the general population. If the level of infertility-related stress is higher, IVF success rate is lower. Findings of our study indicate the need for the specific psychological intervention for all infertility women to improve the IVF success rate. The prevalence of depression symptoms among infertile women, a systematic review and meta-analysis. The prevalence of depression among infertile women was higher than among the general population of a given country, especially in the low and the middle income countries. Appropriate measures, planning, and policy that target the negative effects of depression on infertile women's life should be established to reduce related problems. Stress management during ICSI cycle may slow down first embryo cleavage and accelerate embryo compaction. A pilot randomized control trial. The urine reported SMP seems to be efficient in reducing stress levels among couples undergoing ICSI cycles. Interestingly, it may also influence granulosa cell physiology and embryonal development kinetics in participants with good prognosis. Impact of stress on fertility. Infertile patients respond to stress of being unable to conceive by aggressively pursuing treatments and procedures. Patients withdraw and isolate from family, friends, and community. Most people who cannot get pregnant have an actual physical explanation, but as month after month goes by, feeling of stress, anxiety, and depression often kick in. Impact of stress on fertility. Even if the physical cause of infertility is treated medically, surgery for endometriosis problems with low sperm count and others, it's possible that high levels of stress can still make getting pregnant more difficult. Infertility causes stress, which is aggravated as time passes and the couple remains infertile. Couples participating in an IVF program are highly stressed, especially after a failed IVF cycle. Stress because of IVF procedures, taking time off work for doctor appointments, having blood withdrawn, having pelvis exams, ultrasounds, injections, timing intercourse, various diagnostic procedures, and the cost factor. Efficacy of the reduction of stress before fertility treatment commences. There are evidence that personality dimensions, coping modes, stress susceptibility, and resilience correlates with IVF outcome. Recent studies indicate that stress increases the dropout rates from treatment. Psychological interventions such as behavioral treatment aimed at reducing stress in IVF have shown to be effective in several studies. A recent meta-analysis showed that psychotherapy accompanying IVF also is effective. Short-term goals for male and female fertility patients. Short-term goals for male and fertility patients, reducing of feeling of helplessness through coping with infertility, changes in sexual behavior, modification of negative cognitions as to infertility, overcoming deficiencies in knowledge about infertility, improving marital communication skills. Two main factors appear in chronic stress that determine what influences the psychological condition and mood state in a couple on their fertility treatment. The first factor is the way in which the person handles stressors in general. If that coping way is less than adequate, stress may become chronic, and chronic stress affects fertility. The second factor refers to how the person handles the threat to her or his self esteem, on her or his biological and social value, which results from the knowledge that something is amiss with her and or his fertility. As a result, anxiety and altered mood states in general are common from the moment doubts as to a couple's fertility arise and increase sharply on account of fertility treatment itself. The clinical relevance of the second factor is well established and is up to now the one factor that fertility treatments sometimes take into account and will try to control with psychological approaches. However, more and earlier attempt should be paid to the first factor as chronic stress is an important influence on the treatment outcome. Religious and social beliefs should be considered markers for fertility related stress in their own right. Establishing stress levels before fertility treatment. A physician other than fertility clinic specialist, often gynecologist, usually makes a preliminary diagnosis of infertility. This physician should establish stress levels with the help of validated questionnaires or refer to a psychologist for this purpose to see if there is a reason to suspect the chronic stress plays a significant role. His findings will not yet be affected by the additional stress produced by visits to a fertility clinic. Establishing stress levels before fertility treatment. If indicated, stress reduction techniques should be applied, and after 3 months, stress levels should again be measured with the same questionnaires. The couple is then referred to the fertility clinic. The fertility clinic again establishes stress levels, this time both psychological and biological, and compares findings with the previous uncontaminated measurements to determine the susceptibility to stress treatment. If levels are still over-established, individual thresholds, another 3 months of stress reduction is attempted. Establishing stress levels before fertility treatment. When reduction is obtained, fertility treatment is initiated with concurrent stress management for both. If stress levels remain over the established thresholds, the couple should be advised on the increased probability of a negative result of the fertility treatment and should be recommended to continue with therapy until lower stress levels are attained. However, if they insist, an informed consent should be signed. Establishing stress levels before fertility treatment. Diagnosis of infertility. Establish male, female, chronic, and acute stress levels with validated questionnaires. If over thresholds, intensive stress reduction techniques for 3 months. Establish stress levels and refer to fertility clinic. Establish male and female chronic and acute stress levels with psychological and biological assess. If over threshold, intensive stress reduction through psychological and adjuvant dietary treatments for 3 months. When and if reduction is obtained, initiation fertility treatment with concurrent male and female stress management. Several studies present promising results of psychological interventions leading to higher pregnancy rates, State anxiety has considerable validity as an independent marker for pregnancy rates on account of effect of anxiety on implantation period of the fertility cycle. To improve overall pregnancy rates, it is important not simply a matter of reducing acute stress, but rather of finding ways to improve the efficacy of the adaptive response to stresses. Interventions for stress control and fertility treatment. Procedural measures, protocols to include patient selection according to the existing chronic stress levels and response to acute stressors. Preliminary treatment to reduce anxiety and depression before fertilization cycles are initiated. Psychological means cognitive behavioral therapy, relaxation training, different orientation as to infertility, fertility sabatical permit. Technical means frozen backup semen samples taken at low stress levels outside the fertilization cycle. Furthermore, refinement of fertilization techniques such as removal of the acrosome before ICSI. Neurobiological means establishing individual baselines and specific stress markers, establishing thresholds for referring, monitoring for stress before during the fertility treatment. Ethical and technical reasons for stress management before fertility treatments. Presently available evidence support the following are three assertions. Infertility causes stress in couples involved. Infertility treatments cause stress in the couple involved. Stress may be primary or secondary cause of infertility. For each, the level of evidence is different. The first two having been repeatedly confirmed by acceptable studies, whereas the third is supported by a number of studies that are acceptable in design and execution and should be taken as a probable yet not conclusive evidence. Stress management. No one expects patients to approach fertility treatment stress-free. Finding ways to minimize the stress while pursuing treatment can help. Talk to your partner. Remember, you're not alone. Talk to people with infertility through individual or couple counseling or support groups. Read books on infertility which will help you to be normal and can help you to deal with stress. Stress reduction techniques such as meditation, yoga, progressive muscle relaxation, or acupuncture. Avoid taking too much caffeine or other stimulants. Exercise regularly to release physical and emotional tension. Supplements that can reduce level of serum stress hormones, cortisol and adrenaline can boost the fertility and increase the chances of becoming pregnant. Talking to your partner, remember you're not alone. Talking to people with infertility through individual or couple counseling or support groups. Reading books on infertility which will help you to be normal and can help you to deal with stress. Stress reduction techniques which are meditation, yoga, progressive muscle relaxation or acupuncture. Avoid taking too much of caffeine and other stimulants. Exercise regularly to release physical and emotional tension. For stress and anxiety in infertility, ORAA SPA relieves stress and anxiety, normalizes cortisol levels, improves reproductive function, improves fertility outcome, calm to conceive and improve fertility outcome. Lactium is a milk protein hydrolysate which contains a bioactive decapeptide with anxiolytic properties. This peptide is also called alpha casozepine. Is produced from the milk protein casein. Lactium was developed after 12 years of research in Ingredia Laboratories, France. Lactium works effectively and naturally in stress and anxiety. It causes no side effects, neither addiction nor sedation. Lactium is released from the hypothalamus to the pituitary gland and reduces cortisol and adrenaline. There's a 25% reduction in stress-induced cortisol levels within 3 hours. It reduces stress-induced cortisol levels, reduces GnRH pulsatility, normalizes LH and FSH ratio. In females, it normalizes estrogen production, improves oocyte quality, normalizes progesterone production. In males, it normalizes testosterone production and normalizes spermatogenesis process. Lactium selectively binds to W2 GABA receptor, improves GABA activity, no binding to omega-1 GABA receptor, no sedation. L-theanine, a natural constituent in tea and its effect on mental state, evidence from human electroencephalograph Studies show that it has a direct effect on the brain. L-theanine significantly increases activity in the alpha frequency band, which indicates that it relaxes the mind without inducing drowsiness. ORASPA benefits in stress. It regulates hormone pathway. It reduces stress, induce cortisol and adrenaline. It regulates GnRH and gonadotropin. It regulates estrogen and testosterone. It regulates oogenesis and spermatogenesis. It regulates progesterone, improved endometrial receptivity. It regulates libido. It regulates the neuronal pathway, increase GABA and decrease glutamate activity. Improvement in alpha waves. It gives good quality sleep, improves fertility outcome. ORASPA has no sedation, it has no intolerance, there are no withdrawal symptoms, and there is no addiction. The take-home message. We know that infertility causes stress that leads to anxiety and depression. Stress can make conception more difficult for men and women. Stress reduction techniques, when employed on a regular basis, can improve conception rates. Stress reduction is a non-invasive, less expensive, and ethically acceptable way of improving fertility. Fertility treatment protocol should include stress management, stress reduction as factors of major importance. The professional in reproductive medicine should always test for chronic stress before initiating fertility treatment and adjust selection and treatment protocol accordingly. Thank you.
Thank you very much, ma'am. Am I audible, madam?
Yes, yes.
So thank you very much, madam, for this nice discussion on this very important topic that is stress and infertility. Just give me 1 minute time to check if any question is there, ma'am. Yes, madam. If you can permit, then I can start.
Yes, you can.
Ma'am, what is your practical observation during this infertility treatment and how it is related to the stress?
See, we generally have a clinical psychologist who counsels the patient. They are called counselors. They are in all IVF centers, and they explain to the patient, and they give them the the probabilities of them conceiving, and how they should respond. And they are told that they might take 3 cycles. It's not necessary. The first cycle may click. They might have miscarriages. There might be some complications, so they are counseled, and counseling has a very good impact when we do the IVF cycle. Also, we have seen acupuncture has very good effects, very beneficial effects. So I'm very happy I've started using ORASPA, and I hope it gives us improved success rates.
Thank you very much, madam, for your justification. And just one question, ma'am. Is there any clinical aspects available to determine the stress, or is there any examination
Yes,
available?
there is a questionnaire which we can give the patient, and depending on their response, we can assess how stressed they are. And then depending on that, we refer them to the psychologist, and they are given treatment by the psychologist, and then they come for the IVF treatment.
Thank you very much, madam. And madam, as per from your practical observation, how effective this cortisol and stress? Is there
It is very, very relevant.
No, ma'am. I'm just asking that do you study this cortisol level to check the stress level, or based
So we
on the
have not
questionnaire
been
only?
studying, but I will study now.
Yeah. Thank you very much, ma'am. So thank you very much, madam. I could not find any other things. So if you allow us, then we can conclude this session, ma'am.
Thank you.
Thank you very much, madam, once again for your valuable time on our platform, Shield Connect, and to discuss such important topic of it. Often it is neglected sometimes. So the stress, how it is related to infertility, and what is the impact of this stress condition in this fertility treatment, and how important it is. So thank you once again for your valuable time, ma'am, and in future also we will look forward for some valuable session.